Thanks for having me, guys. I wanted to start out here with a disclaimer. I don't plan to say anything particularly controversial or weird, but just in case, everything that I'm talking about is all my own opinion, my own evidence I gathered. So don't take this as any other pharmacist opinion or Milliman or anyone, only Bryce. Kenneth, we can arm wrestle about this, anything that you just like later.
Spencer will arm wrestle you.
Oh, yes, Spencer will arm wrestle me later about this. Anything in the chat that you guys put, I don't plan to look at it. So if Dave, you want to yell out questions or anything like that, feel free to interrupt me as I'm going. If you guys have questions, I don't plan to just monologue, but if you guys have questions, throw it out there. I won't look at the chat.
Okay, I'll monitor the chat, and then you want people to interrupt with questions verbally or hold until?
Yeah.
Okay.
Yeah, if you interrupt verbally, I'll answer them. If you put it in the chat and Dave doesn't say it, then I'll wait till the end and I'll look at him later. Cool. All right, so what I'm going to start out with is a promise for the presentation, some proof why you should listen to me, and then a plan for the rest of the presentation. So starting out with a promise, I'll provide evidence that pharmacists are prepared and perfectly positioned to support primary care. Perfectly illustrated by this graphic. The primary care physician is collapsing in exhaustion as he's handed off the bottle of pills to the pharmacist. And the pharmacist is so ready for this, he's sprinting the pharmacist to the patient so quickly that his dust has become pills. This is what we have to look forward to if we can utilize pharmacists to support primary care. Some proof. Why should you listen to me at all? I've worked in pharmacy for more than 13 years. I'm a PharmD, licensed pharmacist with a fellowship in population health management. And a lot of those population health programs that I've created were around routine maintenance of chronic conditions and improving validated quality measures. I've created and implemented population health programs that improve the adherence of medications by over 20% PDC, PDC being proportion of days covered. It's like an adherence measure that's commonly used. And we did all of that through routine pharmacy appointments with the pharmacist. And these were mainly focused on the big three, the hypertension, hyperlipidemia, diabetes. But the improvements in adherence also had a halo effect on all the other medications these patients were taking. So not just the big three, all their medications were improved. I also grew up in a rural nowhere Kansas, where the independent pharmacy was our only healthcare institution for most of the patients. And actually now my hometown doesn't even have a pharmacy. So you have to go 30+ minutes to get any kind of healthcare. And finally, I was invited personally to join X Equals Primary Care by Paulius as the first pharmacist, and currently only active pharmacist. Maybe Zane counts now. I saw he introduced himself finally, so maybe Zane counts, but I am the only active pharmacist as of when I wrote this line here on this page. All right, a brief description of what I plan to go through, a brief description of primary care, a little bit about team-based care, pharmacist training and schooling, which I think is particularly important for physicians to hear about. Where are we getting trained? How is it useful for what we're talking about today? And then evidence how pharmacists are already doing this work, and wrapping up with how payers are finally willing to pay pharmacists for some of that clinical expertise. All right, so a brief description of defining of primary care. This definition comes from the World Health Organization. And really what I want to point out is aims to optimize population health and reduce disparities across the population. And this is something that pharmacists can help with, mainly with focusing on these 5 core functions of primary care. So if we're looking at these 5 as a physician, you can imagine that there are some pieces that they're stronger at and some pieces that they are less strong at and could use some support. So if we're thinking about first contact accessibility, the physician has less access to the patient than a pharmacist does. So a pharmacist is seeing patients 12 to 15 times a year, while they're seeing their PCP 2 to 4 times a year, maybe. And so that is more access to the patient. Continuity of care, you have a better relationship with the patient if you're seeing them more often and can help them better think of them as a patient, as a patient-centered in the healthcare system whenever you've had that many touch points with the patient. So those three particularly, I think, are less strong for physicians and could be supplemented by pharmacists. Now, team-based care, I want to highlight that we're not talking about pharmacists taking over primary care from physicians. There are already pharmacists that are doing this kind of work, and they're usually called ambulatory care pharmacists or work in the clinics mostly. But for the rest of this talk, I want you guys to be thinking about pharmacists in the community setting. So we already have pharmacists in clinics. The really underutilized resource are pharmacists in the community setting. So pharmacists can bridge this gap that the physicians have with routinely meeting with patients. You can think of it as they're able to bridge that gap to provide the services more quickly and frequently, because that improves outcomes overall. And you can think of them like an extension of the PCP. So they are taking over, they are just providing some more of those touch points outside of the physician's office. Now, how do the providers feel about that? This first source linked at the bottom here, they looked at provider satisfaction when they worked on pharmacists co-managing patients with the provider, and none of the providers responded that they strongly disliked or even neutral to the pharmacist. They all liked or they strongly liked working with the pharmacist for these programs, and they came out with a 96% overall satisfaction from the provider group. The provider group loved working with pharmacists. Finally, this pharmacist convenience. In the US, 89% of patients live within 5 miles of a pharmacy, and 96% of patients live within 10 miles of a pharmacy. These are much more accessible for patients. They can walk into, talk to a pharmacist without an appointment, can talk to them almost always for free. And there's some points where they might have to pay for things, but almost always walk in, no appointment, talk to the pharmacist for free, and have that brief interaction, and then they can go on their way without having to wait to talk to your primary care physician for the same amount of time, but then there's the 30 minutes before and then the billing after. So that's part of the benefits of utilizing pharmacists as part of the team in primary care. Now, this was the slide that I really wanted to make sure I included to talk to a bunch of physicians. I wanted to show how pharmacists have already been trained for decades to do a lot of this primary care work. Pharmacists are already trained for decades on how to determine the appropriate treatment for a new chronic condition. You think you have a patient, they walk up to you and they are now diagnosed with diabetes as the pharmacist. You can determine the most appropriate treatment for this patient, even if it's a new disease on top of their other 10 diseases and on top of their other 20 medications. These are the kind of scenarios we're given in pharmacy school and in residency, fellowships, clinical rotations. And we could even go as far as making adjustments to the current therapy based on basic labs, point of care testing, and the preferences from the patient from actually talking to them and seeing what they like. And we're community pharmacists specifically are able to do all of this with their eye on the patient as the center of care. So taking into consideration, can this patient afford this medication? Are they able to remain adherent as they to these four different pills a day, or this injection that they don't like needles? Or are they okay with this side effect? If this patient that consistently comes in and talks to you about how amazing their sex life is, you're probably not going to recommend them the SSRI that's going to hit their libido. So maybe you recommend another medication, and keep that in mind when you're thinking about the patient as the center. Pharmacists are doing all this almost always without getting paid for that clinical expertise. So again, they're doing all these things, keeping the patient in the center of care, and very rarely getting paid for that counseling. Here are 2 case studies that show what we're trained in pharmacy school, essentially. So we have a hypertension patient, a diabetes patient. Hypertension doesn't go to her medical appointments, but she is currently diagnosed with hypertension, GERD, kidney disease, hyperthyroidism, not taking any medications. what do you prescribe her? And she has her son that's helping her. So those are the things that we are trained, and these are like actual questions that we would get on exams or in our clinicals or whatever, for how to decide what's the patient be initiated on, or in the case of the diabetes medication, this patient has been adherent to their metformin but still not controlled in their diabetes. What should we be adding on to therapy with this patient who doesn't like injectables? So what are the options? If you want to get extra crazy, rheumatoid arthritis, multiple chronic conditions, patient newly diagnosed with RA, doesn't like injections. What should we be giving the patient? So this is less likely to be your average pharmacist that would be looking at rheumatoid arthritis, but we receive training in all of these other disease states as well, not just the normal, most common, boring, or whatever chronic conditions.
Bryce, can I ask 2 questions that popped up from the chat for you?
Yeah.
So one dumb physician question coming from me.
Yeah.
As far as I know you went over the highlights of training and the clinical aspects, and I think I'm familiar from the outside, but what is taught on the inside, I have some questions on. You talked about treatment for diagnosis. Is there training in pharmacy, clinical or residency on diagnosis, or more once the diagnosis is known, a lot of the training is on appropriate treatment and problem solving that you were talking about, as well as interactions?
Great question. Very little of it is on diagnosing. There's some, but not much. Almost everything we're doing is assuming the physician has already told us this patient has diabetes, has rheumatoid arthritis. Here's your newly diagnosed patient, no medications. Here's their history. Here's everything else in their background. What would you be giving them? What should you start them on? So that's a great question. We're not diagnosing. We're really just doing the initial prescription for these chronic conditions.
And then you may be getting this later, but when pharmacists adjust or prescribe medications, does that get back to the PCP, or do they know about that as part of the collaborative team that kind of exists now? And you may address that later on.
Yeah, I don't specifically talk about that. So most of the time, these pharmacists are still working within the EHR right now, like with the clinic. So if they were doing it within a community pharmacy, they would need to have a way to connect that back. There's a thing with CPESN that they're focused on an e-care plan, which is where they make it interoperable for like EHRs and such, where they can enter these new labs or the adjustments they make and essentially submit it into the EHR. And it's called an e-care plan. So that's kind of the connection that they're trying to make to allow community pharmacists to make these adjustments and get it back to whatever the primary care physician is working out of. But there's not a great way besides like telling the PCP. And if you're the only independent pharmacy in the area, like maybe you have a collaborative practice agreement with the large hospital or whatever, and you just once a month tell them the things you did. I don't know. So there's multiple ways you could go about it, but the only electronic way I've heard of is the e-care plan.
Great. So some are integrated into health systems, and then the community pharmacists, there's maybe one-off connections, but it's not necessarily well established how that interacts yet.
Right. And that's part of they're not able to get paid that often for these services anyways. So not great tracking right now. And I'll finish up with that at the end.
Perfect.
Cool. All right. So getting into where pharmacists are already doing and being successful on delivering on primary care. There's a program, the Michigan Medicine Program, that was utilizing pharmacists to help control uncontrolled blood pressure. And this program was so successful, which you can see there in the participants versus non-participants, that the CDC has taken this up and is going to expand it to all of the Southeast to help improve their uncontrolled blood pressure in that region. So in this case, the pharmacists maintain the blood pressure at much better for 3 months and 6 months control compared to the normal primary care. And they even saw better quality revenue from the quality incentives because they were performing better on their quality measures. They better locked in the patient's medications because they had those adjustments, and that's probably part of the reason that they were actually controlled on their medications or controlled on their blood pressure. And this all led to more time for the primary care physician to spend on other things. So other patients, more complex patients, these patients that were really just, the only issue was uncontrolled blood pressure, they were allowed, they had significantly fewer visits with the PCP, which freed those PCPs up to see other patients. Looking at diabetes, this is a pull from a meta-analysis link there at the bottom, where they're looking at pharmacist programs focused on diabetes, and they saw an average decrease of 1 to 2% in the A1C, with the most significant ones being closer to 3. And actually, I have one that's over 3 that's a little bit later. And they did this mainly seeing the bigger benefit from the patients who were more poorly controlled, and they even saw the benefits with telehealth-based visits with the pharmacist. So any of these programs, they were seeing decreases in the A1C and better control of the patient's diabetes. Looking at hyperlipidemia, this was an automatic referral program. So the patient is eligible for a statin, or they are eligible, they have hyperlipidemia. And so they're automatically referred to a pharmacist. The pharmacist reaches out to them, talks about their personalized pros and cons for starting a statin therapy. And if it's decided it's appropriate, they start the statin therapy. They're allowed to prescribe it for the patient. And looking at this, they saw significant increases in the statin prescription rates. We're talking 31.6% compared to the 15.2 in the normal primary care. And the secondary outcome was, is this actually guideline recommended dose for the statin? The pharmacists were prescribing 24.8% of the time, and the guideline recommended dose of those 31.6% that they prescribed, compared to the 7.7% of the 15.2% of patients that were prescribed. So if you multiply all those numbers together, you end up with pharmacists are 6 times more likely to prescribe the appropriately dosed statin than the usual primary care practice. And the source there at the bottom. All right, so this was a pharmacist that reached out to me to talk about how she's been working in an HMO. And she manages all 3 of these kind of conditions. She pulled the data from 2020 until 2023, and they found that they were reducing their A1C on average 3%. So even better, and including also bringing their blood pressure and LDL within goal. And the big thing that I wanted to point out here was she had no limits on the number of times or the amount of times she could talk to patients, and she was able to prescribe and order blood work under their collaborative practice agreement, which allowed the PCPs in the HMO to focus their time more on the extremely complex or extremely sick patients. All right, so this is more the wheelhouse of the pharmacist optimizing the therapy. At the bottom there is a link to all the CMS evidence for the benefits of MTM, medication therapy management. And because of how good this evidence is now, the CMS has decided to expand their MTM program for Part D starting in 2025. And it's going to take the eligible population from like 9% to like 23%. So we're talking almost a tripling of the number of patients that are going to be eligible for MTM. And that's because they see the value in MTM. It increases the likelihood a patient's going to receive beneficial drugs that can lead to fewer hospitalizations. The actual ROI is 20% to 2,500% on these MTM services from the decreased medical spend. The maybe decreased, maybe increased if they are becoming more adherent to their medications. Fewer hospitalizations, and even if there isn't a direct ROI, they're having better quality of care outcomes, less side effects, more appropriate prescribing of medications. And particularly, these are more valuable for the patients that are higher risk, more disease states, higher risk disease states. So multiple medications, they have their 20 medications, which is too common. They have their mental illness, or they have multiple mental illnesses and multiple chronic conditions. This is why the expansion with CMS has been, because they're increasing it to more chronic conditions that can be included, and more number of drugs that can be included. So it's going to contain more patients that are eligible to get MTM through Part D. This one's kind of fun. So for many young adults and families, really primary care is really just periodic urgent care for these minor illnesses, flu, strep, UTIs. And some states allow pharmacies to do test and treat using their pharmacy point of care testing. but most don't. And so I worked with a previous independent consultant client to set up an urgent care point of care testing at the pharmacy that had a telehealth prescriber kind of stapled on there. And they were able to go in and pay for the test in the pharmacy, get it done there for $40 to $60, which included the telehealth visit, and then submit that strep test or whatever to the telehealth provider. Then within 30 minutes, they'd receive the response back or receive a call from the provider that was on there, usually a nurse practitioner, and have the prescription sent to the pharmacy they were standing at still. So within an hour, for $40 to $60, this patient could get tested, show they had strep, get the prescription, and be at the pharmacy, compared to paying $150 or so and spending hours at the urgent care and then still having to go to the pharmacy to get the prescription afterward. And what's funny, the dermatology consult is actually with Eliana in this group. We partnered with her to do that so that people can get their skin screenings from Modern Ritual at the pharmacy and have it sent to a dermatologist instead of having to wait 6 months to do their skin screenings.
Bryce, can you comment to it? Is that a lucrative field for billing structure for these types of point of care items for pharmacy? And then it just kind of why pharmacists aren't incorporated more into care teams. Is it because they're expensive? Is it because the billing is lower, or is it more of like a cultural aspect?
Clarify the second question for me.
Sure. Why are pharmacists not part of clinical teams commonly everywhere?
They are in hospitals and ambulatory care, but not in the community. The community has not typically done that because of the payment piece, which I'll talk about at the very end here. Not everyone will pay pharmacists for those clinical services. They'll only pay them for dispensing.
Okay, so like part of the flu, COVID, strep stuff you're talking about now too, is that covered payment wise?
No, so in this program, it was cash pay. It was $40, $60 cash pay compared to $150 with insurance at an urgent care clinic. So this was a cash pay service, and yes, lucrative for the pharmacy. I think the pharmacies made 20 or 25 of that 60, 40 to 60. So the pharmacies had pretty good margins on there. That was above the cost of the test. And then a lot of it went to also the telehealth provider. And then the independent client that I had kept the piece that was left, which often wasn't much, but they're hoping to like build up a network of pharmacies to be able to do this at a larger scale.
So Bryce, the question about the care team came from Matt, who works in a hospital system. And Matt, do you have a lot of care teams that incorporate pharmacists?
I mean, not that much. That's why I was asking. It's kind of like a lot of times they'll be like, "Oh, we need like someone to do extra care services. Let's hire an RN." I'm like, that sounds way more expensive, right? In terms of, I guess they can kind of both assess and maybe treat by protocol. Anyway, it seems that's kind of like when calculating the ROI, like what is the salary. That being said, in some of our in-basket care teams, we have a pharmacist baked into that, and oh my God, I love them because both like they can kind of like do refills by protocol, but also like. I was like, hey, my patient said that they have an allergy to this. What's a med swap that I can do? I was like, I guess I could go to UpToDate, but I just like message the pharmacist. It's so much easier. Anyway, clearly, I'm a fan of having pharmacists more embedded into the flow of a care team. But that was like an act of God to get like 2 pharmacists onto that in-basket team.
Yeah, I won't say it's always there's a pharmacist, but every time that I've been in the hospitals, obviously I'm the pharmacist there, so I've seen other pharmacists in these places. That's not always the case, and especially some of the smaller hospitals. But and definitely like the academic institutions, there's a pharmacist rounding with the physicians to offer their insights. Usually it's just one, but with the internist and then the team of docs and the team of residents that are walking around, so it's not quite as impressive. But there's usually a pharmacist there in the larger academic institutions.
So Bryce, I have my own question from earlier. I think this is a good time to ask it. So you were talking about pharmacists treating hypertension, cholesterol, and then doing these point of care tests. So in the whole scope of care debate, a lot of doctors feel like when pharmacists are either diagnosing through these rapid tests or prescribing medicines, it's kind of stepping on our territory. Is there an area where pharmacists feel like physicians are stepping on your territory?
I don't think so. So the main place that pharmacists feel that is their territory is really dispensing, and that's not common for physicians to do that. Like we talked briefly, physicians do that very occasionally, but it's not very common. And I don't know any pharmacists that have been like, I'm offended that some physicians have sometimes dispensed medications. The point of care testing, I think, shouldn't be offensive to physicians, because it's very, as Matt was saying, like there's a protocol. They were positive for this strep test. Here are the options for the medication you can write, the antibiotic they can give them, and the pharmacist can write it. It's not like, well, let me interpret this test and then also incorporate all their other things. It's more straightforward. So I think it's less risky. And pharmacists, like I said earlier, we aren't necessarily trained for diagnosing. So we wouldn't want to be doing that anyways. We want it to be more straightforward. But because these patients aren't able to see an urgent care provider or primary care provider within 27 days or within a few hours, they can go see the pharmacist instead and be able to do these point of care tests. And as long as the line at the pharmacy is, shorter than 3 people or whatever, it's going to be faster.
So would you also feel comfortable if these point of care tests became over the counter, people could do it themselves? They show up with a positive strep test and say, hey, give me my antibiotic.
So part of this program was they did it in front of the pharmacist at the pharmacy to show it was a true test. But that could be weird, where they just walk in with a positive test. But why are they trying to gather a bunch of antibiotics? I don't know. I'm sure there's reasons people would do that. I could see the cost and benefits of having that be the option. Whenever we had these submitted, the pharmacist had to sign their name that I saw them take the test, and when they submit it to the telehealth provider, and then the telehealth provider used their algorithm to decide, okay, is this a straightforward test, and send it to the prescription to this pharmacy. So I don't know. What are your opinions on if they should be able to just walk in with a point of care test as long as it has a straightforward test and treat?
Yeah, well, I guess the line of questioning there is like, okay, if a doctor doesn't need to do it, physician, you guys are PharmDs.
That's right.
Physician doesn't need to do it, anybody at the point of care can do it. Like, why can't the patient just do it themselves? Like you said, it's pretty simple. ABC, if it's positive, write them a med. If it's negative, then not. We had this argument in the legislature, I think when I was a 3rd or 4th year med student, where the doctors lobby said, look, patients don't always know what they have. And if they have a positive, let's say they have a peritonsillar abscess and they just show you this positive strep test and say, give me some antibiotics, right? Like that was what was used during testimony. I mean, what do you say to that?
How often is that happening? So we're looking at trade-offs. How often is that the case where these patients would be taking this medication versus how often would they not have that? And it's just, you save the system a whole bunch of money and the patient a whole bunch of pain and suffering from being able to get this to the pharmacy or test themselves and get it earlier. So there's always trade-offs. It's just how often is the case where the patient could actually harm themselves from doing this test and they have this abscess.
Sure. Yeah, I guess, there's always that scope question of whether the patient can do it themselves versus someone. But I do want to pivot onto payment. So right now, you guys are just doing these prescriptions for free, and it sounds like you guys are trying to get reimbursement from the payers. Do you imagine pharmacists would then be billing E&M codes when they prescribe medicines for hypertension or lipids?
Yeah, I have that later on at the end of the presentation.
All right, I'll let you take control of the presentation again.
Sure. Yeah. We'll get to it for sure. All right. One last point about where pharmacists are currently doing this. There is kind of a specialization. There are disease states that start out requiring a specialist physician, but then they turn primarily into routine primary care around their medication. So HIV and organ transplants are kind of 2 examples. Similar to the rheumatoid arthritis before, this is rarely your normal community pharmacist that they remember everything about HIV and organ transplant. This is usually a specialization, but they would be able to do the routine monitoring and dose adjustments, particularly if we're talking like Matt in the hospital. Definitely the pharmacist can handle those kind of things. And here another patient case from school where you have this patient, multiple chronic conditions, there's their medication, here are their labs, and they only want 1 tablet and they want to start a family. So what would you prescribe them? So these are kind of more edge cases, but specialization that pharmacists can get into where there's primary care, but it's more specialized primary care. All right, so finishing up the growth in payers. So there has been a growth in payers and payers that are willing to pay for these pharmacist expertise as a clinical provider. So this list of 11 bill codes is currently being reimbursed through DocStation. If you guys have heard of DocStation, they're essentially like an EHR for pharmacies. They have the contract set up with the private payers to pay for these clinical services through the pharmacy. The pharmacy enters in these codes and the documentation through DocStation, which is like an EHR, and then they submit it to the payer. So that there are dozens of payers that are willing to pay for pharmacist services, within a certain scope. And there are also now around 24 state Medicaids that are willing to do within a certain scope pharmacist reimbursement for clinical services. But the big thing is provider status. Everybody talks about provider status, and that is specifically around Medicare. So private payers are already paying pharmacists. State Medicaid is already paying pharmacists. Provider status is Medicare, because Medicare has in their legislature and in the law that pharmacists cannot be paid for clinical services. And so the big push is to make pharmacists providers in the law and be able to be reimbursed for their clinical services. So until that happens, the largest population, Medicare, there's not going to be widespread implementation of this until the legislation expands the scope of pharmacy practice and allows pharmacists to bill for these services.
Can I ask you a question on that you talked about CMS expansion for MTM access. My understanding, correct me if I'm wrong, MTM has to be billed under a physician, like affiliate or in collaboration with the providing physician, or has that changed?
Currently, I believe the MTM is done just fee for service to the pharmacist or the pharmacy, usually through like a platform like Outcomes or something that they usually funneled through Outcomes, and then they show up at the community pharmacy on a screen that says, talk to this patient about, do a med rec or comprehensive medication review with the patient. I don't know exactly how the billing goes with the physician side. I just know from the pharmacy side, that's usually what we see. Do a comprehensive medication review with this patient, and you do it, you submit it, and then you get your $60 or whatever for spending that time with the patient. Kenneth, do you have anything else you want to talk about payers?
I actually had a question about the HIV slide you had.
Yeah.
So one thing that we think a lot about in DPC is like, how can we reduce referrals? And so in this case, let's say I have a patient and new diagnosis of HIV. I'm not that comfortable with HIV meds. Do you see a future where I could just refer to the local pharmacist instead of the infectious disease doctor?
Absolutely. Like I said, it might not be just the local pharmacist. It would likely need to be a pharmacist that has either an expertise or it sees a lot of HIV patients at their pharmacy. But absolutely, that's kind of what through this whole education and this whole presentation was really about. You give us the newly diagnosed patient with HIV, and the pharmacist is able to determine the best starting therapy for that, and then manage them on their chronic condition after that.
Are there certifications in that? So you're talking about different expertise and different specialties from a physician side to know who's a good pharmacist to partner on specific populations?
Yeah, there are board certifications on almost every specific disease state you want to see. Most common one that I've seen is diabetes, but I know there's all kinds of specializations out there. If you want some kind of extra credential to say this pharmacist is able to handle this HIV disease state or whatever.
So going on to the payment thing, is there do you see it actually reducing costs rather than adding on if you guys were billing E&M? So if you're a payer, the patient goes to the doctor to go get a diagnosis and then goes to the pharmacist to get their med prescribed. Now you have like 2 E&M codes for previously one process. How do you see pharmacists actually saving money downstream, especially in these VBC models?
Yeah, that's a great question. The answer is because the pharmacists spending their time and being incentivized to spend that extra time doing E&M with the patient actually reduces their later term costs. So definitely in value-based care, they're providing that value. If you saw the ROI earlier, part of that is being able to have discussions with the patient and evaluate, monitor the patient on their new medication or their new disease state. So there's already value there for the pharmacist, and some of them are doing it for free, but way more of them will be doing it, and if they're incentivized to do it because they're getting paid for like doing that clinical service. Something I didn't mention in any of this was pharmacists, like I said, they're mainly reimbursed by dispensing so far, and in a community pharmacy, 70% of the prescriptions you fill, you're going to lose money on those prescriptions, and so you're really only making money on that, well, really like the top 1 to 5% of the medications you fill. And so if there was a way to get away from having to be so reliant on dispensing for your reimbursement, especially when you can't control your reimbursement rates as the pharmacy, because you have to go through the PBM and the insurance, pharmacists would much rather spend time and do something clinical with the patient, like counseling, like E&M, rather than dispense more medications and just try to dispense as many possible and avoid the ones that they lose money on.
Bryce, quick follow-up question. Like, so like in a retail pharmacy, when you say you make money by dispensing, like that just means that like in aggregate over the course of a month, the pharmacy makes money on whatever the margin is, or like is that individual pharmacist depending on the number of pills that they dispense?
Good question. Good question. Yeah, it's the pharmacy. It's the pharmacy makes the money. And I'm thinking almost like the independent pharmacy where the pharmacist is also the owner of the pharmacy. But in your normal, like at Walgreens, the pharmacist has their salary and they have like their quality measures or their business measures that they're trying to hit for a number of scripts filled or whatever. And so that's really the drive to get more volume. The actual salary of the pharmacist isn't reliant on the number of prescriptions they dispense, except for like the quality bonus that CVS gives them.
Yeah. Versus, but you're talking like the private practice pharmacist, right? Where they're the owner and dispenser, so that they're managing their flow of scripts in and scripts out. Okay, got it.
Right, and then that's why many of them are closing, because they can't control their reimbursement rates and they're filling 70% of the medications, they lose money.
Sounds like the primary care physicians. Practice. You'll fit right in with this group.
All right. Well, that's why I'm in the group, right? That's why I was personally invited by Polyus to join this group. All right. I checked off all these things. I believe I covered everything. So I started this with, I'll provide evidence the pharmacists are prepared and perfectly positioned to support primary care. Did I deliver on that? Got a yes from Matt. Kenneth's like, I don't know if I want to say yes to this.
Questions.
I feel like I would add the word targeted primary care, and then I'm good. I can sign off on it.
Oh, sure. I said, okay, support targeted primary care. Got it. All right. Well, that's all I had to talk about today. So I can take other questions, hang out, whatever you guys want to do.
Evan asked a question in the chat, about, so you were talking about PCP shortages and pharmacists filling in. Are there pharmacy shortages or like clinical pharmacist shortages?
In certain sectors, in large chain retail pharmacies, there are, but the number of pharmacists has actually been too many, and that's been more of an issue. A few years after I graduated, they're like, there's too many pharmacists, they're not gonna be able to find jobs and all this. But now nobody wants to work in CVS, Walgreens, or whatever. So there's a shortage in those sectors, but there's too many pharmacists trying to find non-traditional positions. So there's too many, but also not enough.
This is more of an opinion from me than a question maybe, but I feel like for the clinical pharmacy is not always utilizing the skills and training of pharmacists as much as, the retail pharmacy is as much as clinical pharmacy. Like my clinical pharmacists I've worked with have been invaluable for clinical care for me as a primary care physician. I do not have good working relationships with most of the retail pharmacists I work with secondhand, right? And so I think those are very different roles. Do you think that's something that will change over time? There'll either be more clinical roles, or there should be more clinical, or should we be advocating for this? Kind of what's your opinion on that landscape?
The whole point of this presentation was essentially that community pharmacists are trained just as much as the clinical pharmacists. they just aren't utilizing that education. They're being put into a dispensing role and essentially acting as a manager to a retail store. There's very little, like there's clinical work for sure, and you have to know the medications, and there's a lot of pieces that they're using their education, but it's definitely not to the top of their license, if that's what you want to call it. They are not fully executing on their education that they could be in this world that I've described in this presentation.
So I've been using the terms clinical pharmacist to describe somebody who works in like an outpatient setting or a hospital setting, and then the term retail pharmacist for somebody who works in a dispensing setting. Am I using those incorrectly? Would you define those differently?
That sounds accurate to me. Like technically every pharmacist is a clinical pharmacist, like I said, but the way you're using it is likely more correct for their titles, for where they're actually working.
Mm. Yeah, this was great. Sorry to interrupt someone. So this was awesome. In New York, there's a lot of independent pharmacies. And now they're specializing. So now they only do, dermatology or ophthalmology or GI or oncology, things like this. And so, but there's a belief in the New York pharmacists, because we work with them, a lot of them are on our platform, is that if I interfere with the dispensing doctor, because it's a referral based, business, there is going to be some discrepancy, kickback. And is that something that you see in terms of doing a direct to consumer, going direct to the patient, in either, prescribing or doing these tests? Do you find that is a undercurrent to, is not politically right to do that?
So when we had that point of care testing program, we did get some pushback from the clinic that was across from the independent pharmacy or providers that like we should be the ones writing the prescriptions, not a telehealth provider that's somewhere in the state. So there is some mix there on the questions, but like I kind of presented here, like the goal is to give more time for the primary care physicians to spend with these more complex patients that need more time. Because of the physician shortage, like there's not a lack of need, a lack of demand for more patients, for physicians to see more patients. So like you're not going to run out of patients because the pharmacist wrote a prescription for this point of care test for one strep test. It's going to be much more is going to be required, and particularly as we have more patients that are getting older and need more primary care, and there's less people going into primary care, less physicians going into primary care. So I don't see that being an issue, but we did get pushback while we were starting that program.
And I know you've been talking about the clinical role of pharmacists. Are there non-clinical roles of pharmacists in the roles of like in working for payers or other admin roles that I might not think of like as career paths for pharmacists that are trained?
Yeah, absolutely. There's definitely pharmacists that they don't work, like I haven't worked with patients technically since I graduated. So like I'm technically a clinical pharmacist, and in Milliman as a clinical specialist, I'm a clinical specialist compared to actuaries. But compared to clinical pharmacists, they would not agree that I'm clinical. So there are definitely pharmacists that are working in healthcare admin or other non-traditional roles where they're using less of their clinical skills and more of their knowledge of pharmacy, of the healthcare system. And those would not be likely titled clinical pharmacists. They'd be some other title.
So Bryce, so one of the things that I would like to do eventually in my practice is to farm out the stable chronic care patients and maybe some of the basic urgent care. Those are the things that you touched on that pharmacists can do. In my like current paradigm, I was thinking of either hiring a PA or an NP to do that. Why should I hire a pharmacist instead? And Michael, feel free to respond to his response.
Well, the first thing I'll say is the pharmacist is going to be cheaper than a PA. That's the first one. And the pharmacist is going to have more of the benefit, more of the knowledge, the background knowledge in drugs. And so that's, the biggest thing. Beyond that, I don't have a strong reason. I know PAs and NPs that are very good and could easily work in that position, and pharmacists that could easily support them. So I'm not opposed to PAs, NPs, pharmacists, or anything helping in your practice.
Well, yeah, I mean, I can only hire one, right? And the task is chronic stable management of stable chronic conditions as well as basic urgent care, right? So you think pharmacists
Yeah.
could fill that role well?
Yeah, absolutely. As particularly like it depends on what exact chronic conditions we're talking about. Like we said, this targeted primary care, but I absolutely think that a clinical pharmacist and an ambulatory care pharmacist could work in this position. And like I said, if you give them the time and the ability to use their clinical knowledge, they could handle these patients.
Yeah, I actually totally agree with that. Yeah, PAs are definitely way more expensive, and we would be more utilized in diagnosing. That's usually where our strengths lie. Diagnosis and procedures, hands-on care. So I think if it's just management, pharmacists are amazing at following protocols from what I see. And that's how they work, and it's excellent. So I think they function perfectly in that role.
Yeah. Well, you're out of job, Michael. I've hired Bryce.
I haven't watched the chat. I see 31 messages in there, but were there any other questions in there that we haven't been asked so far?
Yeah, go ahead.
I'll give my 2 cents actually on the PharmD versus PA thing too. I think some of it's just like kind of on the volume to it. If you like, Kenneth, I don't know how big like the DPC panel would be, but if you anticipate like a ton of chronic stable patients that just kind of need the babysitting and titration, PharmD kind of works for that. But if you anticipate, and then maybe even cross taper, right? If you anticipate kind of like lots of new patients that may need some like workups, and that's going to be a higher part of your practice building piece, you kind of like have a PA and then I guess jettison Michael and then switch over once you have like because you have your building phase and you have your steady state phase where you are and how those titrate changes over time as your practice builds as well. So anyway,
Yeah, to Matt's point,
times.
PAs will help you scale your practice. We're income generators. So we can generate. I mean, when I was doing fee for service, generating like 1.1 million in dermatology, and I was taking home like a third of that. I mean, not less than a third. Just like $100,000 at the time. And so I think that is like pretty amazing.
Gosh, am I going to go down the scope rabbit hole? Yes. So I guess earlier we were saying because pharmacists are good at, you get the diagnosis and then you do the treatment, right? And then Michael, you're saying PAs will diagnose. So what do I do?
You handle the extra complex patients that are coming into your practice, the ones that aren't just like, oh, they're maintained, they're under control in their chronic conditions or whatever, and there's nothing really intense going on with them. They just need the normal, oh, this kid's sick or whatever. So the patients that are coming in that are complex, that's what you're there for.
Yeah, I'm hearing sit home and sign off charts of patients that
Well,
might.
I mean, that's owning a business. The pharmacists the independent pharmacists that really figure it out, they hand it off to like a COO of their pharmacy chain that has like 4 pharmacies, and they're like, you guys handle this, and then hire individual pharmacists to manage the actual stores. So if you get enough people to have the revenue to sit back and do nothing, then cool.
Yeah,
Yeah.
then you're really going to be screwed, Kenneth. But based on the billing code for complex care, if all the simple stuff's pulled out, the PCPs really need to renegotiate pay structure.
Ken, then you need to do a fellowship. That's what you need to do.
Yes,
Yeah.
fellowship.
Fellowship or bust. But a more serious question, do you know of like clinical pharmacists who have like continuity panels that they follow?
Yeah, I mean, this is essentially what ambulatory care clinics like. They see their patients that come in routinely for it could be for testing their INR because they're on warfarin or whatever. There are routine patients that they see the same patients over and over, and they're like, I'm coming to see my pharmacist Bryce at the clinic instead of always seeing the physician. And when I was on rotations in these clinics, the pharmacist would go in with the primary care provider and have the discussion, and then the primary care provider would step out, and we could finish the conversation with the patient and talk about their medications or whatever else needed to talk about. So it wasn't always like they just came to see us or they just came to see the PCP. They could see both of us briefly or have one of us like introduce it, share the information with the PCP, and then come back and share the results of what we decided to do with the patient.
Bryce, like when I ran a cash pay clinic, we used a pharmacist for MTMs, but we couldn't get it billed basically. So we were just cash paying the pharmacist to do one-off MTMs. Are there other ways that could work? Because I didn't know of a way of doing like a fractionated pharmacist MTM service on staff. But you're saying you could just refer that to any community pharmacist and they can do an MTM and bill through their route potentially?
So they'd have to have that patient assigned to their pharmacy essentially. So the payers, they decide which of these pharmacies is their primary pharmacy, their home pharmacy, and they'll submit it, like it'll go through Outcomes. Outcomes is like the platform where these MTM programs run through, and they're usually billed fee for service. But there's also like an Aspen RX, which is kind of like an Uber of pharmacists, where the pharmacist can just jump in, see, oh, here's a bunch of MTM things that need to be done. You pick it up, you complete the interaction with the patient, you do the CMR or whatever, and then you get your $40 for that time you spent. And so you can do like per patient without having any long-term relationship with the patient, but you jump in and do the clinical service. And that's a lot of how MTM is done now. It's usually done through a call center or something at a mass scale instead of the individual pharmacies.
Kenneth, have you ever used anything in DPC like that, or know if that's integrated into DPC? Because I've never seen that integrated before. I've always just cash rolled it under these like bundled payments. Or Matt, do you have any comment on that? Because that's fascinating to me.
No, I've had again like a lot of my reason my deep level pharmacists is like there was a pharmacy residency at my residency, so like I think we just like co-worked a lot. So like the scope and stuff that pharmacists can do, like I have a deep knowledge and appreciation for, but I've never had to like run the numbers on the other side and be like, how do we make this thing sustainable for those different parts? So people make it work though. Like I've seen it work outside of like just training based scenarios as well, but I don't have details.
So I had a question on because a lot of this is really state dependent from what I see as well. So each state is very different, and then like states like Idaho and even Montana, they're kind of the wild, wild west out there. In that I think they can just diagnose and treat without a standing order. Do you know much about that, and how is that perceived in this whole movement within pharmacy?
I know a little bit about that, and I know that Idaho has long been if you want to call it, the leader of letting the pharmacists do as much as possible, and so they're kind of the envision of what I had here with you diagnose the patient, you hand them off to a pharmacist, and you say, okay, you manage them, you decide what the medication should be. That's kind of why I see eventually pharmacy going. And like in the end, that's where I see it, where they're just handed off for these chronic conditions, determine the initial prescription, and then also manage their labs or whatever. And so that's kind of where Idaho is now. And so I think the rest of the states could get to that point, and that would be once we can do it with Medicare as well and get paid for those services. I think that's the pinnacle of pharmacy where we're looking to get to.
I'm going to stop the recording now for posterity, and then Kenneth can bring out his real spicy takes for everyone.
All right.